So my remit today is really to talk to you about Barrett's esophagus, esophageal cancer, and how we manage that condition, and problems that we see after treatment for esophageal cancer. Many of you will recognise those complications that we see, and many of the things we use to treat those conditions will be applicable to yourselves. Okay, so what do I do? A bit of background about myself. So I'm an upper GI surgeon, and I mainly treat esophageal and gastric cancer. I also deal with patients with reflux, so I do anti-reflux operations. I also deal with a lot of patients with hiatus hernias, and this is where the stomach has moved up into the chest through a congenital weakness or sort of a progressive problem with just weakening in that area. And I deal with a lot of upper GI emergencies, so these can be ruptured esophagus, where someone's vomited and caused a tear, or injuries where one of us has put a scope down and made a tear or an injury to the esophagus where there's been a difficult previous surgery. And I also get a number of referrals of people with complex esophageal conditions, such as yourselves. Okay. So, a bit about reflux. So, it is the biggest pharmaceutical expenditure in the UK. Okay. It affects a huge number of people, so you're not alone. 4% of GP consultations are for treating reflux and managing reflux. People get dental erosions, they get bad esophagitis, they get respiratory problems, as we just heard about, and they get hoarse voice, swelling of the larynx and the vocal cords. Only about 10% ever get to hospital with reflux because the majority are treated in the community. It is increasing in prevalence because of the increasing incidence of obesity, and it is responsible for the higher and increasing rate of adenocarcinoma we're seeing in the UK. In esophageal atresia, it is really common. Up to half patients get reflux, and this is because they lack proper push peristaltic activity in the esophagus because of the nerve disruption, and they lack a proper sphincter at the bottom, as we've just heard about, that's going to prevent that reflux coming back up the esophagus. Up to 20% will have some form of anti-reflux operation to try and resolve that issue. That's always difficult in complex patients because if you've got problems with motility in the esophagus and then you tighten up the bottom of the esophagus, you worry about swallowing problems afterwards and exacerbating those problems. So not easy decisions. The next question really is, what about surveillance in people who have had esophageal atresia? If you've got poor motility and a lax sphincter, you might develop conditions such as Barrett's, which is why I'm going to talk to you today about that. So when do we get referrals generally for people with swallowing problems? Well, the NICE guidance, this is actually now old NICE guidance, but the NICE guidance essentially is referring patients with alarm symptoms. So they need to be scoped within 2 weeks because we're deeply concerned that they may have cancer. These are people with problems with swallowing. That's the predominant problem, okay? Iron deficiency, anemia, or other suspicious tests. If you're over the age of 55, and I think that's quite old, I suggest anyone over the age of 45, with persistent new onset reflux, despite basic treatment, there is concern, certainly that they may have developed some changes in the esophagus, and we want to pick up cancers early, not when they have dysphagia, okay? So when people come for the endoscopy, what do we generally find? Well, as you might expect, the majority are normal. In fact, on the 2-week rule, when we look at the number of endoscopies we do for people with alarm symptoms, the incidence of finding cancer is less than 4%, and out of that 4%, only 2% are actually esophageal cancer. The rest are other cancers that we pick up along the way through all the tests that they go through. So actually, the alarm symptoms that we talk about and people get referred as emergencies for endoscopy for really aren't that indicative of having a cancer. So in a sense, we're screening by doing all this. It's not a very cost-effective way of looking for cancer. 1 in 100 will have Barrett's. If you have reflux, then that incidence of Barrett's increases to about 20%. If you have esophageal atresia, it's about 11 out of 100 people will have Barrett's. Okay? So you are much higher than the general population. If you have reflux and esophageal atresia, I would assume it's much higher than that yet. Again, the worry with Barrett's is it's unstable. Barrett's is essentially stomach lining moving up into the esophagus, it's almost protective. It's not as sensitive. It's a changing that the body develops to stop you getting pain when you get your reflux. That lining is unstable, and those cells may change, and they may become dysplastic, which means they're abnormal. If you have low-grade dysplasia, we tend to try and reduce the acid exposure, and we keep a close eye on it. If it moves into high-grade dysplasia, i.e. very unstable, then the risk of cancer is quite high in that area, and we would treat it. If someone has high-grade dysplasia, the first thing we do is we biopsy it again, because we want to be 100% sure that that is the case. We inspect it very carefully with high-resolution endoscopy, staining techniques to see if there's any abnormal areas that might be early cancer. And then I'll talk to you a little bit about ablating the area, which is what we do. There is an increased cancer risk with Barrett's, but what you've got to remember is you're not definitely going to get cancer if you've got Barrett's. The risk is still quite small, but it does justify some form of surveillance. The incidence is increasing with the increasing rates of reflux. Barrett is a Thomas's man. So he was a consultant surgeon appointed in 1935 at St Thomas's, and he first described in 1950 in his paper the existence of Barrett's esophagus. Interestingly, he thought it was due to a shortened esophagus, therefore everything being pulled up, rather than a secondary change. There may be an element still of truth in that. So what do? We talked about people with Barrett's going to go in surveillance. So there is guidance. We talk about different lengths of Barrett's. So if you've got a very short segment of Barrett's, then probably you're less likely to get cancer than if you've got a very long segment. Okay, so I think the length of the Barrett's is important. There's lots of debate about how frequent you should have endoscopies. It's a lot to go for. Many of you have had endoscopies, and it's not a very pleasant procedure. So to have an endoscopy every 2 years, it comes around pretty quickly, and it's not ideal. But that's where we are at the moment. There is something called the cytosponge that's in progress from Cambridge. Rebecca Fitzgerald's been producing, which is a pull-through sponge that samples cells. But we don't really have the technology everywhere to look at those samples yet. But things are evolving and changing. There's also nasal endoscopy, which is a bit more pleasant for a narrow tube, going from nose, better tolerated. But again, persuading your department to buy those sorts of scopes, that's another big financial outlay, but we'll get there. And as I mentioned about low-grade dysplasia, we treat and monitor. High-grade needs to come to a specialist centre. This is the radiofrequency ablation. So this is burning away that Barrett's area, the high-grade area, and it should replace with normal mucosa. But if you've still got exposure to reflux, then in theory that will still change back to Barrett's or may not heal appropriately. But at least it gets rid of that high-grade dysplasia that you were concerned about in that initial circumstance. You then go on to surveillance after that. Despite having the treatment, you still need surveillance. So it doesn't obliterate the indication for surveillance. So how do I try and control reflux? So I offer anti-reflux operations. The one on the far side is a Nissen's fundoplication, which is probably the most commonly performed procedure. It's a keyhole procedure. So there's 5 ports, small ports, and you take the fundus of the stomach and you wrap it around the base of the esophagus to form a new sphincter. It's not tight, because then you won't be able to swallow through it. I always talk about if you had a hose and you turn the hose on and the water goes through, if you stop the tap, it all refluxes back up the hose. If you rest something on it, like a brick, and you turn the hose on, it goes through, all right? But when you turn the tap off, it doesn't go past that resting thing. So it's a resting, so it's like a kink. So the idea is to have a floppiness and wrap, and it just gives a nice sort of indentation. It's not tight, otherwise you won't be able to swallow properly. That's why a partial fundoplication works, because that's a sort of reiteration of the same thing. It's just resting on top and creating some pressure to try and recreate that valve. The important other thing is that you correct any hiatus hernia, so you bring the stomach back down into the abdominal cavity. And as Professor Maurice was talking about, it's all about pressure differences between the chest and the abdominal cavity. If your chest is above the diaphragm, then you're much more likely to reflux. If you bring that down to the correct position, then that's going to be less of a problem. Okay. Very successful in the right patients. So you've got to do the correct tests, make the correct assessments, and if someone has a hiatus hernia and has confirmed symptomatic reflux with good symptom correlation, which we can measure, then you get good success rates. If you pick the wrong patients for anti-reflux surgery, you don't get good success rates. So it's very important that the surgeon that you see is very careful about who he selects for the procedure. The disadvantages are that people can have problem swallowing, so they may get meats or breads stuck and may have difficulty passing those through. And there is a long-term failure rate. So 5 years, 10 years, 15 years, they loosen and the reflux comes back. 40% of people may be back on some form of acid suppression after about 5 years. Not all those patients have reflux. It may be other things, but it doesn't work forever. Okay. Hiatus hernias. So I see a lot of hiatus hernias. I do probably 1 every 2 weeks, big hiatus hernia. Just to show you what you see when you do the endoscopy, here's the scope going through, and I'm actually looking back up at myself, up into the esophagus. And here you can see that the stomach's disappearing up into the chest. Okay, and you can see here this big bubble of stomach sitting behind the heart. And this is a CT scan of the same patient, an elderly patient, and this is all her stomach sitting behind the heart in the chest, completely full of fluid. This stomach's twisted, so it can't empty anymore. It's called a gastric volvulus. She's got a tube in it to try and decompress it, because at the moment she's persistently vomiting and she's at risk of aspiration, as we talked about earlier, and she'll be in considerable discomfort. Here's another hiatus hernia with this part of the stomach moving up into the chest. The diaphragm's just at this level here, and all that contrast is sitting up in the chest, and it's very difficult for that to empty through back into the stomach proper. While it's stuck up in the top, it can reflux up into your lungs, causing aspiration and problems and reflux. The lower esophageal sphincter will be disrupted, so there'll be no valve mechanism there. This is after the operation, the same patient. The esophagus is back down to the level of the diaphragm, the stomach's been brought down. This compressed area here is an anti-reflux procedure. So you bring the stomach down, repair the diaphragm, and then do a procedure to stop reflux. So that's an anterior fundoplication causing that compression. Okay. Now, the next slide is a video. Any of you are squeamish, then you don't have to watch it. But I thought I'd show you a hiatus hernia during an operation. All right. So don't be alarmed by it. Okay. So just before I start the video, I stand between the patient's legs, okay, and I'm looking upwards, and the screen's over their head, okay? So I'm looking straight up, screen's above the head. This is the diaphragm here. So what I'm looking at is the underside of the diaphragm. The liver's on that side, the spleen's on this side, and this is the hole where the esophagus, on its own, should come through into the abdominal cavity. You can already see a big defect there, so it's very wide. It should be much, much smaller than that to allow the esophagus through. And I'll show you. So when I started, I thought I'd just pull things out of the chest to start repairing the hole. Here we go. So this is all in somebody's chest, okay? And this is the colon here. This is the transverse colon that's up in the chest. So that'll all come down. And in a minute, you'll start to see some stomach. There it is. So the stomach's way, way up in the chest. Okay. Here comes the stomach. And then what we're left with is a very large hole. It's time to go home. And the esophagus will end up being, it'll need a lot more mobilization to get the esophagus down to the abdominal cavity. The operation itself, actually, that's not it. You can't just pull it down and hope for the best, because it will just move straight back up there. You actually have to take the whole sac out of the chest that contains that hernia, because everything's attached to that sac. So the operation itself involves what I'm doing. I won't show you the whole thing, but essentially taking that shell lining out from behind the heart and around the lungs and bringing it down. Then you take that out, and then you do a formal repair of the. I don't know if it will allow me to forward it. It won't really. There's a healthy-looking crust. That's the muscles that lie either side of the hiatus, which is the hole, and that's the muscle I've stitched together again to bring things together. Okay. We'll move on, shall we? So, it only took me 10 minutes, honestly. Esophageal cancer. So who gets it? So men, 50 to 70 years of age. Adenocarcinoma is now the predominant cancer type in the UK. It used to be squamous carcinoma, but with reflux and Barrett's, we're seeing more and more adenocarcinoma. So adenocarcinoma is linked to Barrett's, squamous cell carcinoma, higher in esophagus, linked to smoking. Okay? There are around 7,900 esophageal cancer deaths in the UK every year. That's 22 every day. All right? So it's a big problem. Why do people get esophageal cancer? Well, 66% is related to smoking, so smoking is still that bad thing, and it's impressive to see how little smoking you see these days when you go out and about. So there has been a lot of change there. Diet is obviously important. The Western modern diet is not good, and that's linked with the obesity, and that's still linked with cancer. A lot of healthy foods contain substances which help prevent cancer, so it's important. Body weight, as we talked about, generating reflux. Up to 90% of esophageal cancer is thought to be preventable by correction of those factors. Okay? So, as you might imagine, we're all very keen now in the modern era about preventative medicine, and that's where the government is focusing, and that's how we're going to reduce healthcare costs. Okay? We are very lucky in the UK to be the winners of the highest incidence in Europe. How about that? Would you believe it? So in the UK, it has the highest incidence by a significant amount of esophageal cancer. So when someone has esophageal cancer, the first thing we do is understand the nature of it, how extensive it is. And there's a number of tests that we do. So we do a CT scan, it's a cross-sectional imaging to look at the cancer and to look for any deposits anywhere else. We have a special ultrasound that goes on the end of a telescope, the same as the endoscopy, and that tells us about depth and lymph nodes. And we have a PET scan, which looks for activity, and all these things help us understand what stage that cancer's at. This stops us doing inappropriate surgery. So if someone's got very advanced disease and then you do a big operation on them, you're not actually helping them. Okay? It gives us an idea about prognostic information, because patients want to know, well, how long have I got to live, doc? We can compare outcomes, and we can form definitive treatment plans at the MDT. So what do we want to do? We want to stop Barrett's becoming a cancer. Now you can see the cancer arising within the Barrett's. Okay, so we want to treat the Barrett's at that stage to stop that progression. Because by the time it's got to that, you've only got a 50% chance of being cured. Okay? We do that by ablating bad areas. If we find a nodule or a focal area of cancer in that early stage, we will lift it, suck it, and burn it off. Okay? That's called a mucosal resection. And we can treat the early cancers that way, and that, if it's early enough, will be definitive treatment for them. So we want people early, which is why we do these endoscopies for all these people to try and catch these conditions. Treatment is very aggressive. If you've got an advanced cancer, we hit you with chemotherapy first to try and reduce the disease. We know that even in early cancer, cells spread around the body very early in the disease process. So we use the chemotherapy to pick up any cells that may be shed into the circulation to stop them depositing and forming new cancer areas. Response to therapy, 30-50%, isn't very good. So that means that up to 50% of people we give the chemotherapy to is probably not being that effective. But that's where we are with modern medicine. There are new trials coming through. We're trying new things. We're combining it with radiotherapy. But still, we're still waiting for the genome, the markers that are going to tell us who's sensitive, who's not, and give us more idea about prognosis. We're not far off. Things are happening all the time, but it's probably another decade yet. So what do I do when someone has an esophageal cancer? So I do a similar operation to some people have for the TOFs. The cancer's here in the bottom of the esophagus. So I mobilize the stomach, I make it into a tube, and I bring it up to replace the esophagus, giving someone the equivalent of a hiatus hernia, if you like. So I bring the stomach up into the chest. And it's a recognized procedure, again, for someone who's got absence of the esophagus. You're just replacing it with the stomach. Some of you have had colon used for that purpose. more recently we've been using the stomach. And certainly for all the cancer patients, we do use the stomach, unless it's not available, in which case we would consider using the colon, and I also use the jejunum in rare circumstances. So the important bit is, well, what problems do people get when you do that sort of surgery to them? If you bring the stomach up into the chest, you've knocked off 3 out of the 4 blood vessels that supply the stomach. So it's only running on 1 blood vessel, so the blood supply is very poor. Therefore, the healing's not great, so you get a lot of scarring. So that top joint narrows down because of the poor blood supply. So often people need stretches to open it up to allow them to swallow. You've no longer got a valve at the bottom of the esophagus stopping reflux. In fact, your stomach's up in your chest, so you're going to get acid reflux. So we routinely put people on acid suppression medication to stop the symptoms, but as was pointed out earlier, it doesn't stop them getting the reflux. Okay, so again, we do tell them to lie on their side and other techniques propped up in the bed to stop that fluid coming up, because it may not be acidic, but it still could potentially cause problems in the airways. The pylorus, when we do the esophagectomy for cancer, or when you have esophageal atresia, it's likely the vagus nerves have been interrupted. They supply the pylorus, which is the valve at the bottom of the stomach. If the pylorus doesn't open, then everything just backs up and gives you more regurgitation, reflux problems. So we often have to open up the pylorus to the stretch to allow that stomach to empty, and people find they can eat a lot more in one sitting and find things a lot more comfortable. Dumping syndrome, terrible term, but a very, very simple thing to understand, okay? We mentioned Roux-en-Y earlier. This is a Roux-en-Y reconstruction where the stomach's been removed and the small bowel's been brought up to the esophagus. Here again, see esophagectomy patient with the stomach brought up to the esophagus. The point is, with both these conditions, when you eat and drink, your food or liquids got fast transit straight into the small bowel. Now, if I took food or fluid and just put it straight in my small bowel, I'd be pretty uncomfortable because I'm not used to it and I wouldn't tolerate it. It normally sits in the stomach and it's released very slowly. But you no longer have that hold up. It's going straight through into the small bowel. Okay? So that's going to cause you symptoms. We divide it into 2 areas. We talk about early dumping, which is where the food and fluid have gone straight into the small bowel. They cause cramp, diarrhea, as fluid moves in, and it's uncomfortable, and it's not very nice. And patients will adapt what they eat. They won't drink with their food. They'll avoid certain foods that cause swelling, pasta and things, and try to avoid those symptoms. If you eat a high sugar load, you stimulate the pancreas to release insulin. The insulin levels go right up, and then about an hour later, your glucose levels drop down, and patients report hypoglycemia, so a bit like being diabetic, and they feel dizzy, faint, unwell. So a lot of patients, after they've had their esophagus or stomach removed, will carry sweets with them, knowing when they're about to get problems. If they've had a sugary meal, they'll take one of them to try and sustain it. But most people, when you go to the Esophageal Patients Association, you'll find they all cut the icing off the cake because they know they're going to get symptoms if they eat that sort of sugar load in one go. So, horrible term, but quite a simple condition to understand if you break it down and think about it in those phases. That may help you understand why things go through quickly in yourselves. What's going on, help you to avoid those sorts of symptoms. So what's important after surgery, and this is where we really, again, come round to patients with esophageal atresia. So anyone with cancer surgery, their quality of life is greatly reduced. We know it takes a minimum of a year for people to get over that sort of surgery. And in fact, they have to survive 2 years in order to regain that quality of life at a year. So it's a really big undertaking. I'll talk about post-operative symptoms in a minute, but long-term problems are common. This is why I want to talk to you in a minute about it, because these are the 10 most commonly reported symptoms after that major upper GI surgery. So applicable to anyone with any reconstructive surgery in the esophagus. People are tired, fatigued, the most common symptom, sleeping in the afternoons, not able to complete tasks. That leads to depression and inability to work. That leads to problems, huge psychological morbidity from just having that sort of major surgery. Eating obviously a problem is the esophagus, okay? Yeah, lack of inability to eat large amounts of food, reflux, regurgitation, going out for a meal can be an incredibly traumatic experience. Diarrhea, because of the dumping syndrome, which we mentioned, changes in weight, difficulty in maintaining weight, really struggling to keep, having to monitor that all the time, becoming a focus for your attention, and the family as well. Sadness or depression, sleep problems, that can be due to respiratory or anxiety, nausea, vomiting, and then housing and finances and maintaining job, having to attend hospitals regularly, regular procedures, grossly underreported problem. Okay, so I hope that showed how big a problem this is. In 2015, the government released a cancer strategy because cancer is very topical and they're throwing a lot of money at cancer, but they're not throwing it at benign conditions, such as your condition. Okay? But it's worth noting what is being done so that it can be applied across the board. Access to patient education support events, such as this, these need to be supported. This is where people can come and talk about things and understand their symptoms and engage, and it will help. We can help with signposting to where you go, other patients may have experienced. So getting insurance to go on holiday, that's a huge thing in the Esophageal Patient Association because they've had major surgery, they're a year after the surgery, and they find it very difficult to get insurance to go on a nice holiday after they've had their big surgery, and it's terribly sad. But the OPA will guide them and signpost them to help with that. Stratified follow-up pathways. There is no stratified follow-up pathway for patients with esophageal atresia. You finish being a child, then you become an adult, and then it's into the big wide open world, and you don't really know where to go or who to see or where the expertise is. Very, very difficult. I'm not suggesting you have to go to the clinic all the time, but I am suggesting perhaps that you have access to clinic when you have symptoms or problems, rather than going through a GP, getting referred, and being a random process. For esophageal cancer patients, we move to a phone clinic and we sort of say that, call if you have a problem and then we'll bring you back into the system. What is expected? What sort of post-esophageal problems? You're all here. You're going to get an idea about what might happen. But patients who haven't got access to this or don't even know about it won't know what the potential things are. Okay. The OPA have detailed exactly what they want out of a support structure, and I think that's very important. So patient associations need to tell us what you want, okay? And that's the sort of thing that will come out of a group like this. So what do we have in cancer? We've got the Survivorship Clinic. We run this every Wednesday, and we have input from lots of different people. Okay, so it's a multidisciplinary clinic to try and essentially cover all bases in one sitting. So you're not coming back to lots of different clinics. Okay? It's actually run by our CNS with a dietitian because they listen, they take time, and they're much better than the doctors. And then they have access to all the people around to make sure that we engage and get everything sorted out. So how would it look for a TOF clinic? You can have surgeons, it could be a consultant or a CNS, respiratory physician, patient groups. It's just all about formulating it, and people need to say what they want, really. I've been given the warning, so I need to move on. Just quickly, I'll just show you. So here's an X-ray of a patient of mine with a colonic pull-up. And I just thought I'd just show you to try and explain to you why you're asking about colonic pull-ups and the problems. Well, just watch. Let's start with that one. So this is the CT. This is the colon behind the trachea here. And it will move through. So it will move through in a minute. You can see the dilated colon sitting there behind the airways, all sort of compressed in places, all fluid-filled. And as it goes through the diaphragm, it's even bigger, because it's sort of baggy at that point. So it's trying to get round, and it's stretched, and it all pulls there. It doesn't go through. I mean, even when you put the scope down, you can see there's an easy way through, but it doesn't want to go there. It just wants to pull down, it's the same. So you can see the problem. And then if you look here, this is when the patient swallows. You'll see it's going all over the place, tucked into folds, crevices. So lie on your side, that'll come up. And then you do a Roux en Y and you correct things. That's not going to correct that problem. Very difficult. Just out of interest, this patient had a complete occlusion of the esophagus after a perforation. So the esophagus, complete cut off, no way through, no visible hole at all. So we went with a guide wire from the stomach up to the blind end at the bottom, and then came from the top, and there's a gap that long. Okay? We put a wire, jumped that gap, and then put a stent through. I'm not suggesting that's a way to treat esophageal atresia at all, but that's what we did at an adult recently. So lots of techniques, lots of things evolving, but we do see lots of these problems in adults as well. This lady sadly swallowed by accident some caustic liquid that was by the side of her bed. She got a big stricture. The stent was put in, and the stent eroded straight into the trachea. So every time she ate or drank, it was just going straight into her airway. That all had to come out, the whole thing, and then she had no reconstruction options other than to put the colon underneath the sternum. So she's got her, so literally tunnel under the sternum, bring the colon underneath the sternum, so when she eats and drinks, it goes down under the sternum, down into the stomach. So colonic interposition, slightly different place, lots of different techniques, lots of different ways of doing things. Okay, I just thought I'd show you that. But so, yeah, in summary, we talked a bit about managing the Barrett's, how we treat esophageal cancer. I think for you, it's the functional complications. But most importantly, it's been in the long-term support for you and really telling us what you want. I don't have answers for all your problems, I'm afraid. I think it's a very complex condition, but certainly everyone's here to help. So thank you very much.